Welcome to our presentation of our applied learning case about the development, selecting, and testing of outcome-based quality indicators in physical therapy for patients with non-specific low back pain, which is a mouthful, and we hope that we will be able to explain to you what we did in our project. And with this case, we hope to contribute to continuous quality improvement for physical therapist management of patients with low back pain, and to advance the field of implementation science. I will start with introducing myself. My name is Phillip. I'm a professor of allied health sciences in the Netherlands at Radboud University Medical Center, and also at the George Washington University in Washington, DC, in which I teach and do research in implementation science and in the field of physical therapy and other allied health sciences. And my colleague Koen Verburg will also introduce himself to you.
Hello, my name is Koen Verburg. I'm finishing my PhD thesis right now at the Radboud University Medical Center at the IQ Healthcare Department. And beside that, I'm working as a physical therapist in primary care.
So our case is about low back pain. A bit of background about low back pain. I think you're all aware of low back pain being one of the major health problems worldwide, and a leading cause of disability and an absence of work, actually, of people having low back pain. And about 15% of patients in primary care physical therapy management are patients with low back pain. So it's a huge problem in the world, and physical therapists face a lot of patients with low back pain. But because we don't really understand all the components and all the aspects of low back pain and what it causes and what the different factors are that influence low back pain, there are also a lot of interventions, and we're not always sure how to know which intervention fits best with which patient, and how to use outcomes in order to learn from these treatments that we give to these patients. So because of all these multifactorial factors influencing low back pain and treatments that exist for low back pain, we would like to learn more about what happens in actual physical therapist practice with low back pain patients, what are their treatments, and also what are their outcomes, and to monitor these outcomes and compare outcomes across practices in the field of physical therapy. And our main purpose of doing that is to create a learning environment in which physical therapists can learn from each other and use their outcomes and compare outcomes to improve the quality of their work. And what we've done in our project is that we have used a cycle, which is called the PROM cycle. There you see the picture. The PROM cycle is the cycle that we use for the implementation of patient-reported outcome measures, the so-called PROMs. And what we've done in our project is that we've developed a minimal data set of outcomes and patient-reported outcome measures to be used in patients with low back pain in order to be able to compare outcomes across physical therapist practices and to feed back these outcomes to these practices for quality improvement purposes. So one of the main issues there is that initially the first step in getting there is that you have to select the outcomes to be used and also select the outcome measures to be done with that. So the first three steps of this cycle is to estimate the goal, to select the patient-reported outcomes, and to select the patient-reported outcome measures. And those are the first steps that we undertook in this project to initiate the development of a core set of outcome measures for low back pain, and to use that for quality improvement purposes. And Koen will now take over and tell you a bit more about what exactly we've done and what the results of that project were.
Thank you for the introduction. So what we actually did for the first step to develop a standard set, including patient-reported outcomes and patient-reported outcome measures, we performed a RAND-UCLA modified Delphi study in consecutive steps to reach consensus on the selection of those patient-reported outcomes and associated prompts together with stakeholders. These steps included a literature search, online surveys, interviews with patients, and experts and consensus meetings. And finally, patients associations, professional bodies, and health insurers accepted the final set for the evaluation of physical therapy treatments for patients with non-specific low back pain. And this resulted in the final standard set that included the Quebec Pain Disability Scale and the Oswestry Disability Index that both evaluated the domain physical functioning, the physical specific functioning scale that evaluated activities, the numeric pain rating scale that evaluates pain, and lastly, the global perceived effect that asked about the perceived effect of patients. And lastly, we also included the StartBack screening tool that allocates patients in subgroups based on psychosocial factors, and that also gives insight into the expected persistent low back pain of those subgroups. And with its standard set, we came to the second step of the PROM cycle, namely the testing the patient-reported outcomes, define indicators, and test indicators. For that step, we also performed different steps. First of all, we defined indicators based on the standard set. Then we collected outcomes in daily practice by physical therapists and practices that provided treatment episodes of a lot of patients to estimate the comparability and discriminability of the quality indicators. After that, we conducted focus group interviews with physical therapists. We developed visual feedback reports and presented that to physical therapists and senior researchers. And finally, we asked in the focus groups the physical therapists what their selection was for a final core set of quality indicators. So the first step was to define the different type of indicators. First of all, based on the standard set, we could estimate the mean N score of patients that were treated by physical therapists, the mean change score. The third one was the percentage of patients with a minimal clinical important difference. And the last indicator was the percentage of patients with pre and post treatment measurement was conducted. We only included adult patients and practices that at least provided 30 patients with completed treatment episodes. And we used some case mix factors to adjust for, including age, gender, chronicity, and baseline score. And what is good to remember is that each PROM in the standard set, we were able to develop indicators of it. So, for example, the numeric pain rating scale, we could estimate the N score, the change score, the minimal clinical important difference, and the percentage of pre and post treatments. So after that, we would like to give an example of a quality indicator based on the standard set. First of all, you select the patient-reported outcome, for example, the pain intensity. After that, you examine the patient-reported outcome, which was in our standard set, the numeric pain rating scale. And lastly, an example of an indicator is the mean change score on pain intensity pre and post treatment measured. A visual representation of this kind of indicator is a caterpillar plot. Here you see a lot of practices that treated patients with non-specific low back pain. Each practice provided at least 30 patients. And we're looking at the mean change score and the 95% confidence interval. And what you can see is that a lot of practices are on average based on the 95% confidence interval. Some practices are below average and some practices are higher than average. So one of our goals was to estimate the discriminability of indicators between practices. And here you can see that we that there is and that we were able to discriminate outcomes between physical therapists or physical therapy practices. Another example on practice level. So now you see one practice with different physios working in the same department. And the purple line is the line on the national average, and the other line is the line on practice average. And you can see that some physical therapists are performing a higher change score, and other practices are performing a lower change score, which can be used as basis for learning from each other to search for clarification of those differences. Finally, after a discussion with physical therapists in focus group, we developed a final core set of quality indicators, including process measures that measure the percentage of patients with pre and post treatments for the numeric pain rating scale and patient-specific functioning scale, change scores of measures in the standard set, and lastly, for the global perceived effect, the minimal clinical important difference for patients. And now Phillip is going to take over.
So I would like to finalize this presentation by presenting the final steps in the PROM cycle, which includes the actual use of the outcome measures and the quality indicators in clinical practice, and also to include a process of evaluating the impact of using the indicators and maintaining the currency of the indicators to be used in clinical practice for quality improvement purposes. And one of the main components in doing that is that we have the support from the professional bodies in physical therapy in the Netherlands, who have implemented the use of patient-reported outcome measures and quality indicators in their quality program. So what we have done is that we use feedback reports, the aggregated feedback reports of the outcomes that physical therapists reach in their treatments are being fed back through dashboards, which are being initiated through the electronic health records. And in creating these feedback records, small groups of physical therapists are discussing these outcomes in small quality improvement cycles through peer assessment, in which they review and evaluate each other's outcomes and try to learn from each other in increasing the quality of their work. And that's the process that we're in right now, which is a continuous process, of course, because it's not something you do just overnight. It's something that happens over years. But we have initiated that project to use the patient-reported outcomes. And what we have learned from the project so far and from our continuing activities is that the first and probably foremost aspect is that there should be commitment and trust from the participating physical therapists. So what we need to do is that we feed back reliable data that are valid for showing the quality of physical therapist practice. So we have to focus on increasing the validity and reliability of the data that are being collected, and also make sure that we provide appropriate case mix adjustments in order to be able to compare outcomes between practices for the differences in patients that they may have. And the second point is that we also need commitment of patients. Patients need to fill out these patient-reported outcomes, and we would like them to do that independently without interference from physical therapists, perhaps through a patient portal, via the electronic health record or other means. But patients should be able to do this in their own time, in their own place, independent of the physical therapist, in order to reflect their own views of their health status. And third is that physical therapists should receive tools to use these outcomes and these indicators for their quality improvement purposes. So we need to further build methodology and tools to enable them to learn from each other. So find quality improvement tools that help them to use these outcomes in their quality improvement efforts. And the final step, eventually in the future, would be, could we then use these outcomes as being produced in routine physical therapist practice for external transparency, for publication perhaps on a website that health insurers or patients can see what the outcomes are of physical therapist treatment. And we may also be able to use this for research purposes and to have a collaborative approach by all parties to really make sure that we can show to the outer world what the results are of physical therapist practice. And we hope that in the end, this will result in a learning health system, that the system of physical therapy in a certain context, in our case in the Netherlands, but that could also be done in the United States or at a practice level or at a group practice level, that the data that have been collected in clinical practice can be transformed to the external world, in which researchers and policymakers can use the data to feedback to the clinical practice again. And then we get this learning cycle from generating data to gain knowledge, and gaining knowledge can be used to improve clinical practice, and improving clinical practice will result in new data, and this new data will then increase the knowledge again. So you get the continuous cycle of creating knowledge and using that knowledge again to implement in clinical practice. And that is what quality improvement is about, to have this continuous cycle in which a learning health system is used where research influences practice and practice influences research. With this case example, we hope that we gave you some insight in our project, and we hope that you will be able to use that for your quality improvement purposes as well. And we thank you for your attention.